Welcome to The Explainer. So glad you're joining us today. If you ever looked at hospital reimbursement and just wondered where the leaks are coming from, or why perfectly good claims get snagged in audits, well, you're in exactly the right place. Today, we're going to literally trace a patient's chronological journey through the hospital to really master DRG coding rules. We're going to uncover those snaky, hidden audit vulnerabilities that pop up between admission and discharge, and most importantly, we're going to show you exactly how to avoid them. Let's just jump right in.
Here's our roadmap for today's Explainer. We've got a 5-part journey lined up for us. We'll start with the basics of DRGs, then we'll move on to understanding CCs and MCCs. From there, we'll dive into the official ICD-10 coding guidelines before tackling a really big one, the documentation turnover trap. And finally, we'll wrap it all up with avoiding vulnerabilities and denials.
All right, Part 1, the basics of DRGs, establishing the foundation. Okay, let's dive into this. So every patient journey kicks off at that critical moment of hospital admission, right? And that brings us to the absolute bedrock of inpatient coding. According to the Uniform Hospital Discharge Dataset, or UHDDS for short, the principal diagnosis is defined as the condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital for care. Now, I want you to really zero in on that phrase established after study. This isn't just a best guess at triage, okay? It is the ultimate proven anchor that actually drives our diagnosis-related group or DRG assignments. It tells the primary story of exactly why that patient needed a bed in the first place. Now, while the principal diagnosis is absolutely the heavyweight champion of DRG assignment, it is for sure the primary driver, it actually doesn't act entirely alone. Other clinical factors can step in and completely pivot that baseline assignment. We're talking about things like pregnancy-related diagnoses or, significant surgical procedures. These elements set our baseline, but as we all know, hospital stays rarely just stay perfectly at the baseline.
Which brings us to Part 2, understanding CCs and MCCs, the stay and severity.
So as the patient actually occupies the bed and their stay progresses, clinical complexity really begins to reveal itself. If we trace our history back a bit, 2008 was the year the CMS Inpatient Prospective Payment System Final Rule established the modern severity tiers we use today. CMS basically looked at secondary diagnosis codes and asked a really simple question: to what extent does this specific condition increase hospital resource use? And from that, they built a 3-tiered system: non-CC, CC, and MCC. So, tracing our patient's stay. Day 1 is that admission and base DRG assignment. But as we move into days 2 through 5, secondary conditions, comorbidities or CCs, and major comorbidities, MCCs, start getting documented. And by day 6, at discharge, this whole shebang culminates in a final tiered MS-DRG weighting.
What's literally fascinating here is the sheer cascading effect that capturing a single CC or MCC has on a hospital's whole ecosystem. Think about it. When we capture these complications, we are clinically proving a higher severity of illness and an elevated risk of mortality. And because of that above-average intensity of resource utilization, well, the case rightfully moves to a higher-weighted DRG. Practically speaking, that increases financial reimbursement, it medically accounts for a longer length of stay, and it impacts the hospital's overall case mix, accurately reflecting that the facility is, in fact, treating a much sicker population. But, and it's a big but, to actually get credit for this, the documentation has to be completely bulletproof.
All right, Part 3, official ICD-10 coding guidelines, the rulebook.
Because the stakes are just so high here, we have to play strictly by the official rules that govern how we capture these severities. And honestly, this is where the logic of clinical documentation gets super interesting. The official ICD-10 CM guidelines specifically state that the assignment of a diagnosis code is based on the provider's diagnostic statement that the condition exists. The provider's statement that the patient has a particular condition is sufficient. Guys, this is massive. The guidelines are explicitly telling us that code assignment is not based on the clinical criteria the provider used to establish the diagnosis. In other words, the coder's job isn't to play doctor and verify all the lab values. No, the coder's job is to code the provider's explicit diagnostic statement. But there's a really, really important catch to this rule.
The absolute crucial point is this: what actually happens when the medical record contradicts itself? What if, say, the ER physician says one thing and the hospitalist says another? Well, the official guidelines are crystal clear on this. If there is conflicting medical record documentation, you can't just guess, and you definitely cannot just pick the highest paying code. You must query the provider. This rule is the ultimate defense against audits, and honestly, it leads us perfectly into the absolute most dangerous part of the hospital stay.
Let's move to Part 4, the documentation turnover trap, discharge and disconnects. Okay, so we're now in the late stages of our patient's journey, getting ready for discharge. But this is exactly where the attending provider's responsibility to reconcile diagnoses often just completely falls apart. I like to call this the higher acuity domino effect. Just think about the logic here for a second. A patient with a really high acuity, maybe dealing with multiple MCCs, inherently requires a longer length of stay. But those longer stays mean the patient is surviving across multiple shifts, weekends, rotation schedules, and that naturally increases attending provider turnover. The result? The documentation becomes totally disjointed. Providers start relying on cloned progress notes, essentially just copying and pasting from the day before, often bringing yesterday's typos right along with them, and those cloned notes completely fail to reflect the patient's actual current reality at discharge. By the time a late-stage provider sits down to write the discharge summary, they're really only looking at the immediate concerns of that specific day. The domino falls, and suddenly significant conditions that were present on admission are either entirely missing from the discharge summary or they're severely downgraded.
And this perfectly illustrates another layer of that trap. It's that classic friction between the specialist and the attending provider. Very often you've got multiple specialists heavily engaged in the patient's care, right? A specialist consult might brilliantly identify a complex diagnosis, an event that is separately codable and highly relevant. But then the attending provider, who is ultimately the one responsible for managing the overarching patient care and reconciling all those diagnoses, simply fails to acknowledge the specialist's findings, or they fail to incorporate them into the final care plan at discharge. Now, while technically a specialist's statement is sufficient to code from, these massive unvalidated inconsistencies between what the specialist noted and what the attending summarized, that is exactly the kind of fuel that creates completely undefensible denials.
Bringing us to our final section, Part 5, Avoiding Vulnerabilities and Denials, the NSTEMI case study.
To really drive this whole concept home, let's look at a real-world case study to see how these exact discharge disconnects literally trigger financially devastating audit denials. So in our case study, the patient comes into the emergency department. The ED notes, the admission history and physical, the consulting cardiology notes, they all agree. The patient presented with a non-ST elevation myocardial infarction, or an NSTEMI. Now, for coding purposes, an NSTEMI is a major complication or comorbidity, an MCC. It carries significant weight. But look what happens at the very end of the stay. A totally different late-stage provider dictates the discharge summary and lists the condition as unstable angina. While unstable angina is just a regular CC, it has a much lower weight. Because codes are assigned according to the acuity of conditions present at admission, this glaring acuity mismatch instantly invites an audit. The auditor sees an MCC at admission, a CC at discharge, and boom, they deny the claim due to inconsistency.
So, when you're faced with that kind of glaring discrepancy, how do you actually build your defense? I mean, you can't just code the NSTEMI and cross your fingers, hoping for the best. You have to ask the critical, clinical validation questions. Did the patient actually meet the clinical criteria for an NSTEMI? Was the condition worked up with additional diagnostic tests during the stay? Was it actively treated? Or maybe did subsequent tests actually rule it out? If there is strong clinical support for the NSTEMI in the record, but the discharge summary says unstable angina, you've got conflicting documentation. And as we learned from our rulebook earlier, a query to the discharging provider is absolutely 100% necessary to resolve it before that bill ever drops.
Which brings us to our final slide, and honestly, a really critical question I want to leave you with today. Are your discharge summaries telling the whole story? We've traced this entire journey today from the UHDDS definitions to the nuances of MS-DRG severities, all the way through the real dangers of provider turnover and the vital importance of clinical validation. If your facility's discharge summaries are basically just a snapshot of the patient's final 24 hours, you are leaving legitimate, hard-earned reimbursement on the table. And worse, you're leaving the door wide open for auditors. So take a hard look at your documentation continuity, empower your coding teams to query those discrepancies, and lock down your inpatient coding. Thank you so much for joining me on this explainer today. Stay curious, stay focused, and keep learning.